Auzubillahi minash-shaytanir-rajim. Bismillahir-rahmanir-rahim. I am Professor Dr. Muhammad Badar, and we are inshallah we will learn about the third lecture of diabetes mellitus today. And in today's lecture, we will discuss the targets of the glycemic control, non-pharmacological management of diabetes, and principles of pharmacological therapy. And about in detail about the pharmacological therapy, that would be the last lecture of series of diabetes mellitus, and next series will be of the complications of diabetes. So always remember, when we have to treat something, we know what we are going to achieve, and then we lay down a plan to achieve those targets. So for the glycemic control and diabetes, we are we know that certain agencies in the world, they laid some targets, like American Diabetes Association targets for the glycemic control, or IDF targets. For IDF stands for International Diabetes Federation targets. They are that fasting plasma glucose should be remain between 80 to 120 milligram per deciliter, and if it is more than 140, we should adjust our pharmacological therapy, or we should give emphasis on non-pharmacological measures. The same is with the bedtime glucose or postprandial glucose. It should remain between 100 to 140, and if it is 160, we should take some action. And about HbA1c, the goal is it should be less than 7, and when it is more than 8, it means that action is needed at that time. So remember that if somebody asks you in examination that what are the goals of treatment for hyperglycemia in patients of diabetes, I'm talking about hyperglycemia because management of diabetes mellitus is not just controlling blood glucose. It includes the management of lipids, it includes the management of weight, it includes look for macrovascular and microvascular complications and managing them as well. Because currently in this lecture we are only concerned about the management of hyperglycemia, so we will stick to that, and we should know the targets of hyperglycemia. So the targets of glycemic control for the treatment of diabetes are: fasting should remain between 80 to 120, postprandial or bedtime glucose should remain between 100 to 140, and HbA1c should remain below 7. More than 8, HbA1c needs action. Action means that we should look for non-pharmacological measures. Either the patient is compliant or not, we should reconsider the pharmacological management. Either we should add on a second or third agent, or we should increase the dose of the first agent which is being taken by the patient. We will be discussing it in detail when we will be talking about the management of diabetes, pharmacological management of the diabetes. So when we talk about the management of diabetes, there is non-pharmacological management, that is diet and exercise, then certain oral hypoglycemic agents, then incretin-based therapy. Incretin-based therapy is relatively a newer concept. That is why it is mentioned here separately. And once all the oral hypoglycemic agents they fail to control diabetes, insulin therapy should be considered in that case for type 2 as well. In dietary treatment should aim at ensuring weight control. Number one, if the patient is overweight, we should look for an ideal BMI in that patient, and we should tailor the diet according to the weight of the patient. And other thing is important, we should not forget that nutritional requirements of patients should not be ignored, and that diet should also allow good glycemic control with blood glucose levels as close to normal as possible, and they also should be aiming at correcting any associated blood lipid abnormalities. So dietary treatment, when we are going to plan, there are four things which should be kept in mind. Number one, that diet should ensure weight control. Dietary requirements or nutritional requirements of the person should not be ignored. Number three, the diet which is being advocated, that should allow good glycemic control with blood glucose levels as close to normal as possible. By this, by it means that the diet which is being taken by the person, that should be low in glycemic index. Glycemic index, if you understand it, I can explain it in the manner that once you take a food and it increases blood glucose in instantly, that has got high glycemic index, like glucose, like sugar, like juices. But once you take a food that takes time to be absorbed and there is a gradual increase in blood glucose levels, it means that food is low in glycemic index. That is the complex carbohydrates, protein intake, that all they are all having low glycemic index. So in diabetic patients we should prefer a food which is low in glycemic index. And the fourth point which should be kept in mind while tailoring a diet plan for a person is that it should also correct the associated blood lipid abnormalities. Dietary fat should provide 25 to 30% of total intake of the calories, but saturated fat intake should not exceed 10% of the total energy. So, our aim when we are tailoring a diet plan for a person is that cholesterol consumption should be restricted and limited to 300 milligram or less. Amongst the 25 to 30% of total intake, the majority of the dietary fat should be in polyunsaturated form, and saturated fat should be as less as 10% of the total energy. That is very important and that should be kept in mind. Protein intake can range between 10 to 15% of the total energy, that is zero point 0.1 to 1 gram per kg of the desired body weight. Requirements increase for children and during pregnancy. Protein should be derived from both animal and vegetable sources. Some of us consider that carbohydrates should not be given to a diabetic patient, but that is not correct. The diet of a diabetic patient is also balanced diet. Balanced diet means that it should contain all the basic nutrients in the diet. It should be containing dietary fat, protein, carbohydrates. But a important thing which is to be kept in mind, that despite the fact that carbohydrate still makes the major portion of the meals, the total calorie content of the diet, carbohydrates should be complex and high in fiber, so that they should be, as I have mentioned in the last slide, they should be uh, having low glycemic index. So for low glycemic index carbohydrates, they should be complex and they should be high in fiber. Juices are not allowed. The patient may take fruits which are low in glycemic index. The high glycemic index food should also be discouraged, like mango and grapes. But other fruits are allowed, and but their juices are not allowed because of their high glycemic index. Excessive salt intake is to be avoided. It should be particularly restricted in the people with hypertension and those with nephropathy, because in those cases salt may aggravate the disease. Another thing is important, that salt cannot be ignored altogether, because if we restrict the salt 100%, the patient will not be able to take the food due to taste problems. So it should be considered that excessive salt should be restricted, and judicious use of salt should be allowed. Physical activity promotes weight reduction and improves insulin sensitivity, thus lowering blood glucose levels. Together with dietary treatment, a program of regular physical activity and exercise should be considered for each person. Such a program must be tailored to the individual's health status and fitness. People should, however, be educated about the potential risk of hypoglycemia and how to avoid it. The one thing which should be considered while we advise our regular exercise program to the patient is that every person who is beyond 40 years of age, his stress testing is mandatory before advising him strenuous exercise. Always start with minimal exercise and minor exercise, and then gradually build it. The targets are that they should be at least 150 minutes of exercise, moderate exercise in a week is recommended for all the patients. Now we come to the pharmacological therapy. Oral antidiabetic agents, they are the bigonides, insulin secretagogues, they are the sulfonylureas, then insulin secretagogues, non-sulfonylureas, alpha glucosidase inhibitors, thiazolidine diones, dipeptidyl peptidase 4 inhibitors, and sodium glucose cotransporter 2 inhibitors. These are the certain groups of oral hypoglycemic agents. Why so many groups are needed? This is a very important and a thing which should be understood before we start learning about the individual groups. It should be kept in mind is that in homeostasis of the liver, homeostasis of the glucose, there are multiple organs which are involved in the body, and the center position definitely holds by the pancreas and the liver. The other organs which are responsible for the homeostasis of blood glucose, they are the adipose tissues or muscles, then stomach definitely, intestines which is responsible for the absorption of the carbohydrates and the sugars, and then kidney which is responsible for the excretion of excessive glucose and reabsorption of the blood glucose. And it should be considered that it should be kept in mind that if the patient is having persistent hyperglycemia, the threshold for reabsorption of the glucose by the kidneys is reset, and even at higher levels of blood glucose, that is not spilled into the urine. Keeping in mind all these facts, certain groups are developed which act on different places in this cascade of homeostasis of blood glucose. Like when we talk about the adipose tissue or the peripheral tissues, adipose tissue and muscles, then peripheral glucose uptake is enhanced by thiazolidine diones and metformin. Thiazolidine diones takes part about 80% of the part in peripheral tissue uptake, and metformin about 20% of the part. And when we talk about the liver, the glucose production and glucose uptake, that is controlled by metformin and thiazolidine diones. Both of these agents, they increases the insulin sensitivity in the liver, and independent of the insulin, even they can definitely metformin, thiazolidine diones, they are true insulin sensitizers, and they are responsible for glucose uptake in the liver and majorly in the adipose tissues and muscles. And metformin is responsible for major action on the liver, and that is responsible for the glucose uptake and reducing the process of gluconeogenesis. Then comes the major organ which is responsible for the production of insulin and glucagon. Insulin secretion is controlled by, when we talk about the pharmacological agents, there are sulfonylureas which are responsible for the insulin secretion from the pancreas. Then there are non-sulfonylurea secretagogues, the repaglinide and netiglinide. Their action almost is the same, but the time of action is very short. They are used to treat postprandial hyperglycemia. And then comes the incretin based therapies, which definitely in response to food, they are responsible for the secretion of insulin from the beta cells of the pancreas. The other hormone which is very important in glucose homeostasis and which is released by pancreas, that is glucagon secretion from the alpha cells in the islets of Langerhans. Glucagon is basically the antagonizing hormone of the glucose of the insulin, and it is secreted in the conditions of hypoglycemia or in prolonged fasting to maintain blood glucose levels in prolonged fasting states. That is also misregulated in diabetic patients, and incretin based therapies are the only pharmacological agents which are responsible for the suppression of glucagon secretion from the liver, from the pancreas, sorry. Then comes the intestines, which are responsible for the glucose absorption, and glucose absorption is hampered by an agent called alpha glucosidase inhibitors. These are brush border enzyme inhibitors, and they stop conversion of disaccharides into monosaccharides, and that is the reason why the carbohydrates are not absorbed by these agents. Then the agents which acts on stomach, they are incretin based therapies, and they are responsible for delaying of the gastric emptying. And a relatively newer pharmacological agent are the SGLT2 inhibitor. They are responsible for inhibiting glucose reabsorption from the kidneys, and there are many positive effects which are nowadays associated with the use of SGLT2 inhibitors, and we will be discussing it in detail while we will be studying the pharmacological agents in detail in the next lecture, inshallah. So what are the factors which should be kept in mind at the end of this lecture are: number one, whenever we have to treat something, we have to make certain targets. We have to set certain targets. To the targets for control of hyperglycemia, or the targets of blood glucose levels in diabetic patients are set, and they are in fasting state. They should be between 80 to 120 milligram per deciliter, and in postprandial state or at the night time they should be below 140 milligram per deciliter. And as we talk about HbA1c, it should not exceed 7, and that is the target set by ADA and IDF. Then we should be considering about the non-pharmacological measures. In non-pharmacological measures, diet and exercise both are important, and dietary measurements, there should be kept in mind that all the nutritional factors should be kept in mind before advising dietary therapy or dietary management to the patients of diabetes. There should be a balanced diet, and weight reduction should also be considered while advising the diet without depriving the person of important nutrients. Then comes the exercise plan. One thing which is very important before prescribing exercise plan to a person is that its cardiovascular status or comorbidities should be kept in mind, so that aggressive exercise may lead to severe hypoglycemia and then certain problems, and definitely cardiovascular events may be precipitated by severe exercise if the person is not prone to it, is not in a habit of doing such exercises. So always start with the warm up maneuvers, and then the target of exercise or target of physical activity in a patient with diabetes is about 150 minutes of moderate exercise. That means brisk walk is enough for 150 minutes a week. And then comes the pharmacological therapy, and for the understanding of pharmacological therapy, we should be knowing that there are certain organs which are taking part in the homeostasis of blood glucose in the body, and the pivotal role is played by the pancreas and the liver, and then peripheral tissues like adipose tissue and muscle, then the stomach, intestine, and kidneys. All of them are playing a very major role in the homeostasis of blood glucose levels. So certain pharmacological agents are developed to act upon these different organs to control the blood glucose levels. If we know it and understand it, the understanding of pharmacological therapy would be easy for us. So the agents which act upon pancreas are sulfonylureas, non-sulfonyl secretagogues, incretin-based therapies. The agents which are responsible for the action on liver, they are metformin, thiazolidine diones. The agents which are responsible for peripheral tissue action, they are primarily thiazolidine diones and then secondarily metformin. The agents which hamper the glucose absorption from the intestines are alpha glucosidase inhibitors, and the agents which are responsible for decreased glucose reabsorption from the kidneys, they are the SGLT2 inhibitors. And finally, the pharmacological agents which are responsible for gastric emptying, delaying of the gastric emptying, they are the incretin based therapy. So in next lecture, inshallah, we will try to cover slightly in detail about these pharmacological agents. Thank you very much.